All right, so for all of you who have been on our learning management system calls, know that we talk about different disease processes and then do the clinical and regulatory aspect of these disease processes. Most of you who have already been on the call know that you can go on to aerolib.com, scroll down to the Aerolib Learning Management System tab, and it takes you on to the Adobe Captivate Prime login. A lot of you who have been listening to us on various topics already have logins, and those who don't can always contact me for that. It opens up your profile page. There are a number of courses in the catalogs. And if you choose one specific, for example, acute kidney injury, it opens up another core content page where there are videos, documents, PowerPoint presentations. Once you complete these, you get points and you can compare them with your colleagues. Your managers will have full reporting capability on seeing who's registered for what course, how much they've completed. In addition, you get access to Aorta forums. It has more than 78,000 views, 160 members. And what we do is, this is an Android and a Google Play app where we talk about regulatory issues. For example, the 2 midnight rule, inpatient hospital reviews, and tremendously popular. It's a free app available for all the viewers. So what we've done so far, we started this project of adding content into the learning management system earlier this year. We've already covered topics of COPD, sepsis, acute kidney injury, pneumonia, congestive heart failure, seizures, abdominal pain, TIA, syncope, and atrial arrhythmias. We'll be going into more topics in the future. What we do is talk about the 2 midnight rule, spectrum of regulators, what the red flags in documentation is, secondary diagnosis, comorbid conditions, and then talk about some tips to avoid hitting off RAC audits. Now, in addition to the topics, we've already put in acute respiratory failure, case analysis, 3D mapping, some topics about physician advisor basics, anatomy of a medical record, the Moon Notice, condition code 44s, decision trees, value proposition of a physician advisor program, resistance to change. What we added in the last few weeks is chest pain, UTI, the perfect appeal letter, MACRA, MIPS, HCCs. Dr. Charda is working on some regulatory appeals presentations. There's one on cellulitis coming in January. Now, these are all our native presentations. And what we've done is in December, earlier this month, we got licenses to show some of the top 3 presentations from the Physician Advisor Bootcamp. In addition, Aerolib also tied up with Appeal Academy, and Bob Soltis, he's a former ALJ from Omaha, has made 2 wonderful video presentations about proposed decisions, the inpatient decision template, and these are exclusively for Aerolib. So, be tuned for more organizations tying up with the Aerolib learning management system to provide content to our users. A little disclaimer, and again, this is basic stuff saying Interqual is a product of McKesson. CPT is trademarked by the American Medical Association. Now, a lot of you familiar with our process know that we start off with this spectrum of auditors slide. And what this shows is the bottom 2, they're in green because they're for routine compliance. QIOs and certs, these are actually friends of the hospital. When we go into the yellow zone, the MACs, MICs, and the RACs, these are where compliance oversight happens. And when they refer for fraudulent billing to organizations that do legal oversight, that's when we know we're in trouble. So the Department of Justice, the OIG, and the ZPIC, these are all legal oversight organizations. So when the RAC program started many years back, that was a 3-year demonstration. And the idea was to detect and correct past improper payments, as well as prevent future improper payments from the Medicare trust funds. Now, they started recovering a lot of money, and what the RAC showed is high-risk medical necessity vulnerabilities for inpatient hospitals. And you can see cardiac defibrillators, heart failure, shock, pacemaker, chest pain. These are among the top 4. But our topic today is medical back problems, which has an improper payment amount of at least $9 billion. Now, CMS has introduced the MIPS and the APM as part of the MACRA and the CHIP Reauthorization Act, as we call the MACRA for Medicare reform. And what that does is it puts hospitals on a different playing field where they can either lose 4%, 5%, 7 or 9% over the next few years, or gain that amount. And so, they need to be participating in quality resource use, clinical practice improvement activities, and then meaningful use of the certified EHR technology. Another track is the APM track, where there is incentive payment, but then they're excluded from the MIPS. And as time goes by, these will become more clearer. But what is important to know is 2017 is the base collection year for payments that will start happening in 2019. So technically, now is the time to make sure your providers are fully in compliant with regulatory and clinical education. We talked about what new CMS incentives are about value-based care. So MACRA was one of them with the MIPS and the APM. Well, there are next generation ACOs, comprehensive primary care plus programs, and then chronic care management programs. Now, one thing that we've been asked during our concurrent review for providers is, what do auditors look for? And it's a simple answer. They are looking for services that are reasonable, that are medically necessary, that meet professional recognized standards of care, and that could these services be delivered in an alternative setting. So they are looking for all these points. So let's talk with our topic about back pain, and you see what we'll go through over the next few slides is our model of some definitions, some pathophysiology, signs, symptoms, what do we do for examination. We talk about secondary diagnosis, comorbid conditions, we'll touch about ICD-9 and 10, some screening tools and some coding tips on this topic. So low back pain, it's a chronic pain syndrome responsible for the greatest clinical, social, economic, and public health burden. Now, this is a disabling pain syndrome, and 1999 and 2010, there was a 106% increase in PCP referrals for patients with low back pain to specialist physicians. Now, in 2009, a survey was done where at least 1/3 of the adults reported low back pain in the last 3 months. In addition to neck pain, knee pain, shoulder pain, finger pain, hip pain, low back pain accounted for about 28% just in the last 3 months. In 2010, the cost impact of chronic back pain ranged from 560 to 635 billion. Now, of that, pain care accounted for almost half, 261 to 300 billion, but lost productivity from pain ranged from another 300 to 355 billion. Now, 15% of total cost of healthcare with up to 85% coming from indirect costs. So back pain is an expensive disease for the country, which is why RACs are now focusing on what sort of documentation is needed for medical necessity of back pain treatment as well as hospitalization. So risk factors for developing back pain, there's smoking, obesity, age, vitamin D deficiency. Now, what is important to note is at least 2/3 of patients, they recover from their back pain by 6 weeks, and about 80 to 90% recover by 12 weeks. And what is important to know is the most amount of cost goes in the first six weeks for one, diagnosing this pain as well as treating this pain. Now, this is a very busy slide, but why it's important is we generally use back pain as a generic term. However, when we are looking at the pathoanatomic basis, I'm not going to read this slide, but I want you to know that there is lumbar disc disorders way down to failed back surgery syndromes. And so people who have access to the learning management system, it's advised you pause at this slide, read the different bases of back pains, because this is very important when it comes to billing and ICD-10. Specificity of what exactly in terms of anatomic basis is going on determines what sort of payments the hospital gets. So for example, when there is neurogenic claudication, The history needs to reflect pain enveloping the buttocks, posterior thigh, calf, and groin, often, but not always associated with lumbar spine stenosis. And so this slide will give you a guidance on what is important to note in terms of chief complaints history, and when we move on to some next slides, what's important in the examination. Now, risk factors for progression of low back pain to chronic low back pain. Now, there is psychosocial factors and there is specific work-related factors. Again, this is the point where these points need to be asked by each patient presenting to the hospital or to your primary care clinic in terms of what sort of factors they are to risk factors for back pain. And, some of them for work-related factors is high physical demands, inability to modify work, high levels of job stress. When we talk about psychosocial factors, there's low self-efficacy, family reinforcement of illness behavior, social and financial problems. And it's noted, I think there was a study that happened 4 or 5 years ago where they talked about back pain in relation to social economic factors, and they found illiteracy and poverty contributed to more progression of acute low back pain. Now, what are the prognostic factors of unsatisfactory treatment response? And these, similar to the causes of back pain in terms of epidemiology, as you can see, substance abuse, previous surgeries, tobacco use, BMI, sleep disorders. Now, all this is a spectrum of treatment response in terms of psychosocial factors, in terms of work-related factors. And so back pain is not just an anatomic lumbar or thoracic or sacral anatomic defect. It does encompass the whole epidemiology of the patient, and that's where it's important to treat not only the acute anatomic cause, but worry about the social issues also. Now, failed back surgery syndrome. With the increase in the number of complaints for back pain, that has led to the increased number of back pain surgeries. And then following that, a few years later, the failed back surgery syndromes that are now showing up. And again, there's risk factors for poor outcomes. Again, there's preoperative, postoperative, and surgical. When we look at preoperative, anxiety, depression, misidentification of the pain origin, obesity, smoking. When we look at surgical, whether this patient was a poor candidate for surgical technique to begin with. And then when we look at some postoperative causes, infections, hematoma, myofascial pains, these are all risk factors for poor outcomes. Now, again, a very busy slide in terms of examination for back pain, but important because auditors do look at what sort of examination has been done not only during the hospitalization, but even prior during your outpatient visits for authorization for advanced imaging. So if you went in for just based on a history and requested for an MRI of the back, a lot of the insurance companies, a lot of pre-auths are now requiring full examination, as well as what sort of treatment was given, whether there was a failure of that treatment, whether the physical therapy was done. And so this is very important for not only your hospitalist, but your ER physician, as well as your neurologist and neurosurgeon on appropriate examination for gait, in standing, in sitting, kneeling positions. And all these point to what sort of dermatomal or neurological level the defect is in. Again, people with the LMS can pause at this slide and then revise their examination procedures. Now, low back pain has a lot of red flags, and when I mean red flags, this is where you simply don't give them Tylenol, Motrin. So if there is a possible etiology of malignancy, whether the patient has a history of current cancer diagnosis, unexplained weight loss, progressive non-mechanical pain, altered sensation from the trunk down, whether there are vertebral fractures. So the elderly patients, there's long-term steroid use, altered sensation again from trunk down, and then pain worsening with flexion, pulling up the spine. Cauda equina syndrome, which can be an emergency in terms of neurosurgical response. Acute onset urinary retention are some of the symptoms. Loss of anal sphincter tone or fecal incontinence. Saddle anesthesia. progressive motor weakness in the legs, and more than one nerve root involvement, gait disturbances, vertebral infections. So whether these patients are systemically unwell, whether there's mechanical pain, IV drug abuse. So when we have red flags in our history and physical, then we need to worry about these etiologies of malignancy, vertebral fractures, infections, and then cord-equina syndrome. Now, low back pain categories, there's a lot of literature on how to classify it. Category 1 is what we just talked about, low back pain due to serious disease, whether it is cancer, infection, inflammatory changes. Low back pain with cord or cord root compression, which is where there's cord equina, disc prolapse, in addition to the cancer, infection, inflammatory. And then there is non-specific low back pain. So this is where the total days in pain during the last 12 months are less than a week, more than 5 weeks, more than 13 weeks, or the whole year. Whether this is associated with restriction of daily activities due to the low back pain. And there are a number of authors who have made different categories. Our suggestion is use the category that you feel you have read about, and then be consistent in those across your patients. A lot of times you may have to use categories developed by Medicare or developed by your insurance companies when you're ordering MRIs or ordering surgeries. But be aware that there are a number of different types of categories. Now, guidelines for hospitalization of low back pain, and the reason this is important is over the last few months, we have seen a number of patients who complain of low back pain, inability to move, and question from the ER and the hospitalist is, should they be in the hospital? Or should they be as inpatient? Should they be as observation? Should they be an outpatient? Do we get an MRI? There were some very nice medical treatment guidelines from the Washington State Department of Labor and Industries. And I put in the link here. Again, when you have the PDF file on the LMS, simply click on it. It will take you to the full slide deck by the Washington State Department of Labor. But as a description, they have divided low back pain into 3 categories and 3 groups. One is where trauma is suspected. So, if a patient fell from a height and spinal fracture is suspected. Where acute trauma isn't suspected, they divided it into 2 groups. So one where the patient has neurological findings that are suspected to be acute or progressive, or patient has low back pain without evidence of acute or progressive neurological findings. So let's go over some of these. So our first is acute major trauma suspected. This is where a patient fell down. The back injury occurred within the last 7 days of presentation. That trauma happened, whether this is a fall or a heavy object falling on the patient. And the physician suspects an acute spinal fracture, spinal cord injury, or nerve root injury. And what they describe is this patient needs to have an individualized evaluation, treatment, hospital admission criteria, and then a post-admission management process. But these are the ones where patients are admitted, pain control, whether it's in the form of orals or continuous IV, PCA, whether advanced imaging is done or not. In our group 2, this is where an acute major back trauma is not suspected, but you do have neurological findings which are suspected to be active or progressive. So in this particular case, there's no history of any injury, but patient complains of symptoms that suggest this neurological deficit, and the examining physician indicates that this may be an acute or progressive neurological deficit. Now, what they recommend is this patient should be hospitalized, and hospitalization should be brief. If a patient has this neurological deficit, the reason to keep them in the hospital is to facilitate a surgical decision making or to provide a close observation for further progression of the disease. These are patients that get admitted, they're in an observation, an MRI has been ordered, a neurosurgical consult is placed, and in terms of pain control, whether non-steroidals, antidepressants, or opiates are being given to this patient. Our group 3 is this patients, and we see a lot of them, especially during the holiday season, is they complain of back pain without an evidence of an acute or progressive neurological finding. So there's no history of trauma. Patient continues to complain of back pain. You don't find anything on exam. There's no evidence of a neurological deficit. And in this case, the valid reason for hospitalizing this patient may be that he or she cannot manage basic activities of daily living at home. Now, what they recommend is hospitalization should be brief. Advanced imaging is rarely indicated, and pain management again is non-steroidals, antidepressants, opiate, depending on what this patient is on currently. So stacking of different opioids or stacking of multiple medications is not recommended, and that's where a full history and physical need to be done. Now, there have been a lot of articles on back pain. There's one, and the links provided below is the cost controversy crisis, low back pain and the health of the public. There's one about evaluating and managing acute low back pain in the primary care setting. Again, links have been provided. People who have access to LMS simply click on the links. They'll take you to the full article and you can read them. But the reason to present them in this webinar is, even though we feel anatomically we've identified the cause of the back pain, treatments are not same for everyone, and treatments are expensive. They need not be always done in an acute inpatient hospital setting. Back pain treatments can be done as an outpatient, can be done as a long-term management protocol in the office setting also. Now, Medicare has, releases these quarterly newsletters and compliance newsletters. This one I pulled out from January 2013. It's a 14-page newsletter, very interesting to read. But let's move on to page 2 of this, where they talk about back and neck procedures excluding spinal fusion. So what Medicare is trying to say is exactly what we've been pointing out. They want a full documentation for that particular complaint, and I put it in the red boxes. They want to know the severity of the signs and symptoms exhibited by the patient. They want to know the medical predictability of something adverse happening to this patient if treatment is not provided. They want justification for the need for diagnostic studies, that should they be performed in an outpatient setting? Should they be performed in an inpatient setting? Does this patient need to be in the hospital? And then the availability of diagnostic procedures at the time and at the location where the patient presents. So a lot of times, if you think a chordae equina syndrome is suspected, patient is having a 2-day history of worsening acute neurological deficit, and this patient presents to your office, that the urgency for the MRI, the steroids, the neurosurgical intervention is far greater that can be done in an outpatient setting for 2 or 3 weeks to get everything arranged. Those are the ones that need to be admitted. Whether they need to be inpatient or not, that's a different question based on complexity of the care that's needed. Now, in addition to the disease process, there are national coverage guidelines for imaging, and so there's an NCD for when an MRI should be done. And again, this is based on the cms.gov website. The link's been provided up. This is an extensive document, not only for MRI of the lumbar or thoracic spines, but MRI for brains also. Now we come to this important topic of spinal surgery, and we're going to dedicate a few slides to this. What we've seen is 80% of patients that are evaluated by neurosurgeons are referred for, they've been referred for spinal pain, but surgery is indicated in less than 10%. So one rule of thumb is spinal surgery in acute low back pain is limited to patients with severe or progressive weakness or chordae equina syndrome. A lot of surgical decompression procedures, whether this is open discectomy, microdiscectomy, laminectomy, disc arthroplasty, they are being performed, and our guidance to the entire team is some of these procedures are on the inpatient list, some of them are not on CMS's inpatient only procedure list, and that differs with every year that happens. So your neurosurgeon or their office manager or your billing department need to be cognizant of the fact that if these procedures are being performed, what sort of CPT code is being used and whether they're part of the inpatient only list or not, whether if it is a Medicare patient. If it is your commercial patients, they may have guidelines for their own pre-auth process. Now, an article that's been around for at least 19 years says there are 4 indications for intervertebral disc surgery. And one is progressive motor weakness from nerve root injury that's demonstrated on clinical exam or an EMG. There is bowel or bladder disturbance or other signs of spinal cord compression. There is incapacitating nerve root pain despite conservative treatment for at least 4 weeks. And the fourth is recurrent incapacitating pain despite conservative treatment. Now, why these 4 points are important is this is what forms the basis for your history physical exam, your medical decision making. Whether this is for your hospitalist, whether this is for a neurologist, a neurosurgeon, or your ER physician. If patient has one of these 4 or more, then they know this patient needs to be admitted. They know this patient needs to be evaluated for spinal surgery. Now, some of the procedures listed here require prior authorizations depending on what CPT code is being used. And a lot of, this is beyond the realm of the primary care physician. But again, if the neurosurgeon is planning lumbar fusions, decompressions, their office knows what CPT codes to use. They need to make sure those auths are in place to prevent any unnecessary charges to the patient. And again, when a prior auth has been requested for a surgical procedure, a lot of times, whether this is the auditor, whether this is the insurance company, they require clinical diagnosis, they require date of onset of pain syndromes or symptoms, physical exam, diagnostic image results, non-operative treatment modalities, what sort of treatment, when was it given, how long was it given, was it physical therapy, epidural injections, chiropractic or osteopathic manipulations, heart pads, massages, ice packs, or medication. So this forms the basis of a full record. Now, for every case that we've discussed, there are some questions that need to be asked. Why does this patient remain in the hospital in terms of severity of illness and intensity of service? So what is the condition that can only be treated in an acute care facility? And then what treatment is being provided that can only be performed in an acute care facility? It's just not enough to say the level of sickness is there. You need to demonstrate that this patient requires the hospitalization because the treatment that's being given can only be done in the acute care facility. Now, there are comorbid conditions and major comorbid conditions. Comorbid conditions, these are complicated conditions. These are secondary diagnoses that can increase the severity of illness, the morbidity, mortality, length of stay, utilization of resources. And then if you have a major comorbid condition that shows that the risk is substantially greater than a simple CC. Now, in terms of back pain, a lot of times we have patients who present with IV drug abuse, valve changes, congestive heart failure, and we find out there is a vertebral abscess. So in those cases, that's where terminology and semantics makes a huge difference, whether there's concurrent DKAs, hypertensive encephalopathies. This is where a lot of the users, and we are able to track people on the LMS, they pause at this slide, refresh their terminologies, and then go on with documentation. Now, ICD-10 has a number of codes for back pain, and these are the M series, starting from cervical, thoracic, lumbar, unspecified, and then dorsalgia, which is M54, which is one of the commonest used ICD-10 codes. When we talk about M51, this is the thoracolumbar spine sacral disease. You can see how specific you need to be in the documentation for your coder to bill up to the second decimal points. M54, the dorsalgias, these are the lumbagos with sciatica. You need to be specific, right side, left side, and then the simple low back pain, which is the M54.5. This is the most commonest ICD-10 code that's being used. So one of the questions that's being asked is, how does all this affect physicians? And we all know, based on the 2 midnight rule, that there was a shift from complex decision making to time-based definitions. I think what is important is documentation is really critical for whether it's low back pain or any other disease process. And the bottom line turns out to be is whether you adapt, you migrate, or you perish. Now, all these links are what we've discussed in the presentation here. And again, like I said, if you have access logins for the learning management system, this will be part of the LMS later today. And then you can click on whatever topic that you'd like.